start recording. Now we're recording. Okay, let's go. Today we have chapter 14 and 15. I already post the review, so you have access to the review as I send the review through the reminding app. And also remember, in instruction block right there, you have the review for this week. Okay. Please go over the review before you take the test. Okay, over the review. When you finish the review, you have any question, just let me know, call me, send me a message, whatever. Okay, so let's gonna start. Chapter 14 is about alteration in homeostasis and blood coagulation. So we are gonna be talking about coagulations. Okay. Hemostasis is the arrest of bleeding. So in other words, hemostasis is stop bleeding. Okay. When you have any damage to the blood vessels, then your body activate the hemostasis process. A stage of hemostasis, we have primary hemostasis, initial response to vascular injury, and involve the platelets. Okay, that's extremely important. Hemostasis is divided in primary and secondary. Okay, primary is through the platelets, and secondary is when you activate the coagulation factor. Secondary hemostasis involve coagulation factor and fibrin clot. Okay, when you form the clot. Platelets, another name for platelets is thrombocytes. Okay, platelets adhere to the endothelial collagen exposed by trauma. After adhesion, they become activated and initiate degranulation, the release of alpha granules and dense body. Let me see, alpha granules, blood coagulation. Okay, listen, platelet. I'm going to explain the platelet in a better way. When you have any blood damage, remember that the blood vessels inside the inner layer of the blood vessels is the endothelium. When you damage the endothelium, you activate the platelets. Okay. Then what happens? Platelet get activated. Then the platelet get aggregation. Okay. They start getting together one to another. Okay. And then when they are one to another, they form the plug. Okay. That's how the platelets work. Okay. Now we have blood coagulation factor. Most are plasma protein in inactive state, international standard nomenclature factor. This is extremely important. All coagulation factors are synthesized, that means they are made by the liver. Okay, so you have problem with the liver, you have problem with coagulation. That's why sometimes, and you're gonna face that when you get to the hospital, patients with liver problems, it's extremely hard to make a surgery in those patients. Okay, it's extremely hard because for sure they are gonna have problem with bleeding. Okay, now we have blood coagulation factor. We have factor 2, 7, 9, 10, protein C and S. All those factors are depending on vitamin K. Okay, why? Because vitamin K activate one enzyme, and that enzyme promote the maturation of those clotting factors. Okay, that's why it's so important. Antithrombin 3 and protein C promote anticoagulation. Antithrombin C is the one that destroy the fibrin clot at the end. Okay, when you stop the bleeding, you have to dissolve the fibrin clot. Okay, and protein S and C, it binds to phospholipid and stimulate the release of tissue plasminogen activator, inhibiting fibrinolysis. Protein S and C, they facilitate the coagulation. Okay. That's why it's so important when you give a medication to the patient, especially warfarin, because warfarin inhibits vitamin K. When you give warfarin to the patient, you have to be very careful because the first thing that you inhibit is this. And then if you inhibit this, then you are going to promote coagulation. And when you give warfarin, you want to promote anticoagulation, okay? That's why it's blood thinner, okay? To inhibit coagulation. That's why most of the time when you give warfarin, nowadays basically just a few patients that are in warfarin because we have new medication. When you give warfarin to the patient, you have to bridge. That is called bridge, heparin bridge. You put the patient in heparin, and 3 to 5 days later, you start the patient in warfarin. Now, let's go fibrin clot. That's at the end of the secondary hemostasis, intrinsic pathway and extrinsic pathway. Okay, this is extremely important. Intrinsic and extrinsic pathway. Okay, that's extremely important. Why? Because the coagulation pathway is divided like this. Okay, you have to make this. Okay, and that's how you remember the coagulation pathway. Okay, this is the intrinsic and this is the extrinsic. Okay, and from here, let me see, hold on. From here, all this is the common pathway. In the common pathway, you have factor 10, factor 5, and factor 2. In the intrinsic pathway, you have factor, oh, sorry. What is this? You have factor 9, factor 8, factor 11, factor 12. In the extrinsic pathway, then you have factor 7 and factor 13. Now, intrinsic pathway when you get in, is related to PTT, okay? And heparin, because heparin inhibit the intrinsic pathway. Extrinsic pathway are related to PT, okay? Prothrombin time. And is more related to warfarin, okay? Okay, fibrin clot, intrinsic and extrinsic pathway lead to the common final pathway, of course, factor 10, 5, and 2, and so on. But remember, it's extremely important that you learn the intrinsic pathway and extrinsic pathway, okay? Now we have fibrinolysis, clot dissolution. At the end, when you stop all the bleeding, you have to dissolve that clot, okay? Because if you don't dissolve that clot, then that clot at one point is gonna be released and can produce thromboembolism, okay? Obstruction in one part of your body, and that produce an infarction, okay? Could be in the lungs, in the heart, any part of your body that may obstruction of the blood. Okay, the process factor 12, those are the one that released by plasminogen activator, okay, to dissolve the clot, okay? And plasmin digest fibrinogen and fibrin and inactivate factor 5 and 8. Fibrinolysis, clot dissolutions, again, fibrin split products is when you dissolve the clot, those are the ends product, okay? Severe factor help control the balance and clot formation and clot dissolution. Include in patient history, physical examination, clinical assessment, laboratory tests, evaluation of homeostasis and coagulation. You always have to do physical examination, lab tests, because you have to make sure. The three more important tests is PT, PTT, and bleeding time. Okay, PT, PTT, and bleeding time. Okay, PT and PTT, secondary hemostasis, clotting factor. Bleeding time, primary hemostasis, platelets. Okay, that's extremely important. If you have prolonged of the bleeding time, that means that you have problem with platelets. If you have prolonged PT or PTT, that means you have problem with clotting factor. PTT factor 9, 8, 11, 12. PT factor 7 and 13. The most important is 7, okay? 13 is not so relevant. The most important is 7. Why? Because 7 is related with vitamin K and warfarin. Okay, especially indicator for personal family history of bleeding, active bleeding that is on response to a standard intervention, a screening before surgery, ongoing evaluation, clinical assessment, personal and family history. Always you have to do family history, not for this, for any type of condition, okay? Medication history, of course, medication history, because if you have problem with bleeding, could be because you are taking, for example, aspirin or derivative of aspirin, medication that contain aspirin, okay? Salicylate, okay? Remember that aspirin is acetyl salicylic, that is salicylate. Pepto-Bismol contains salicylate, so yeah, you have to be very careful. Never give Pepto-Bismol to children, okay, because that contains salicylate. Aspirin is completely contraindicated in pediatric population, okay? You never use aspirin in pediatric population. There is only one condition that you use aspirin in pediatric population, and is this disease, Kawasaki disease. Okay, we have also non-steroidal anti-inflammatory agent, of course, non-steroidal anti-inflammatory, this NSAID, that means non-steroidal anti-inflammatory agents. NSAID and aspirin basically have the same mechanism of action. What is the mechanism of action? Is how the medication work in your body, and they work through the inhibition of the arachidonic acid. Arachidonic acid is a password. You don't have to know that, but that you have an idea, okay? And they inhibit the COX-1 and COX-2. COX means cyclooxygenase 1 and cyclooxygenase 2, and that inhibit the coagulation, okay? Chemotherapy and thrombolytic agents. Okay, thrombolytic agent, we have the TPAs and also anticoagulations, okay? Of course, if you have problem with bleeding, you have to ask, are you in anticoagulation? Yes. Okay, clinical assessment, pallor, jaundice, hemarthrosis. Hemarthrosis is extremely important, okay? Why? Because that's basically how you differentiate hemophilias, okay? Hemophilias, hemarthrosis, hemophilia, hemarthrosis, okay? Also, we have telangiectasia, petechia, purpura, and so on. Clinical assessments, occult or frank bleeding, okay? Frank bleeding is like bleeding, actual bleeding that you see the blood, that's frank bleeding, okay? Occult blood is could be in the feces, is the most common one, and is most of the time related with sometimes related with cancer, okay, colon cancer, okay. When you have blood in the feces, it's called hematochezia or melena, okay. Melena is digestive blood, okay. That means the feces is gonna be like dark, like black, okay. Hematochezia is bright red blood per rectum, okay. Urine is hematuria. Vomitus, when you vomit, is hematemesis. Nasal drainage, nasal discharge is epistaxis. Sputum is hemoptysis. Hemoptysis is when you cough blood. Excessive menstrual bleeding is menorrhagia or menometrorrhagia. Laboratory tests, always you have to do the CBC to identify anemia. If you have bleeding for prolonged time, that produce anemia. platelet count, peripheral smear to see if there is any problem with the morphology of the platelet. And right here you have, those are the three main, we have 1, 2, 3, and 4. Okay, I'm gonna explain the 4, but the most important is bleeding time, and bleeding time is related to, who knows the answer? It's right here, platelet, okay? Bleeding time, platelet, okay? Always. PT-INR is related to extrinsic pathway, okay? Coagulation factor and extrinsic pathway. What is the coagulation factor? That is right there. Who knows the answer? Seven and 13, but the most important is 7. PTT is extrinsic pathway, and then in PTT you have factor A, 9, 11, 12. You have to know A, 9, 11 because A, problem with factor A, hemophilia A, problem with factor 9, hemophilia B, and problem with factor 11, hemophilia C. Okay. And D-dimers is the fibrinolysis. Okay. Also, D-dimer is a final product. When you dissolve the fibrin clot, you have D-dimers. Okay. And we have question number 1. A 4-year-old boy is brought to the emergency department after taking an overdose of his baby sister NSAID. He found in his backpack. Which of the following laboratory tests will be abnormal? Okay, remember that NSAID. No D. Okay. Listen, NSAIDs, and it's right here. Let me go back. You have it around here. I don't know where. NSAIDs is problem with bleeding time. Okay. Okay, remember that NSAID and aspirin, they inhibit platelet, okay, and they increase bleeding time. Okay, that's why it's problem with bleeding time. Okay, so this question is extremely hard. Platelet count shouldn't be here because it's also affected by the NSAID. Yes, I know your question. Yeah, that's why I say that platelet count shouldn't be here. Okay, it shouldn't be here to make a fair equation. Platelet count shouldn't be here. Okay, yeah, it shouldn't be here, right here. Okay, because for example, you are giving aspirin to the patient, and one of the tests that you do is CBC, and in the CBC you are gonna see the platelet. You are giving aspirin to the patient, and the platelet drop like dramatically really fast, then it's problem with the aspirin. You have to remove the aspirin because the patient is going to develop bleeding. Okay, let's keep going. Vascular and platelet disorder. Vascular disorder, primary causes bleeding is a problem with the vascular component. Primary hemostasis may be acquired or inherited. Inherited is like hemophilias. Vascular purpura, abnormality of the vessel or support tissue, purpura, petechia, patches of petechia present, allergy purpura, autoimmune process, Ehlers-Danlos syndrome, that's a genetic disease, and it's a problem with collagen. And remember that we need collagen for the coagulation. Okay. Also, we have deficiency. Vitamin C deficiency is related with bleeding. Why? Because it's involved in the collagen synthesis. In the collagen synthesis, you need vitamin C. That's why sometimes if you have vitamin C deficiency, you are gonna develop like petechias, okay? Aging, loss of subcutaneous fat, and change in connective tissue. Remember that connective tissue is collagen, and then you have problem with collagen, you develop bleeding. Vascular purpura, location of purpura depend on causative agents. Diagnosis is one of the exclusive after platelet and coagulation disorder are ruled out. Tourniquet test. Tourniquet test is basically, let me open my camera right here that you see me on the camera. Can you see me on the video? Yes, no? Yes, okay. I'm your professor. Hello. Okay, listen, tourniquet is that you put right here the stethoscope. You inflate the uh, the cuff that you use to measure the blood pressure. The cuff, you put it right here. You inflate the cuff, wait like 1 minute, and then when you remove the cuff, you're gonna be a lot of like red points. That's petechia, and that means that you have bleeding. Also, that test is used for when you have problem with one infection that is called malaria. ITP, listen, let me see. Who put ITP? McCarthy, you put ITP. I think we have ITP right here. Okay, no. ITP is another disease. ITP means idiopathic thrombocytopenia purpura. Okay. Vascular purpura right here. I don't know why they use this name, but they are talking about yes, it's that one. It's idiopathic thrombocytopenia, ITP, idiopathic thrombocytopenia purpura. That's the vascular purpura. Okay, because the other disease is TTP, thrombotic thrombocytopenia purpura. Okay, that's the real name of that disease. And it's an exclusion. Why? Because you have to exclude all the other disease, and if the sign and symptom of the patient doesn't fit in any disease, then you have the ITP. That's the ITP. Right here, they are referring to ITP. Okay. I don't know if they covered TTP, but if you want to know TTP, TTP is another problem with the platelet. And those patients, how do you know those patients? Because you have to say fat, like fat, R, N. Okay, fat RNs mean fever, anemia, thrombocytopenia, renal problem, and neurological problem. Okay, those are the signs and symptoms of TTP. Okay, let's keep going. Right here we have hereditary hemorrhagic telangiectasia, Osler-Weber ring disease. That's another disease. It's an autosomal dominant trait. That's a genetic condition, and basically you have to know just the name because that's an extremely weird condition that you are never gonna see in your life. Right here you have those patients have a lot of multiple telangiectasias. Telangiectasias is like petechias. Repeated episode of bleeding. Treatment support this is humidify the air. Topical hemostasis agent, cauterization, iron replacement, and laser therapy. Now we have platelet disorder. In platelet disorder, we have primary causes bleeding, maybe again acquired or inherited. We have thrombocytopenia. Remember, thrombocytes mean platelet. That means that this the thrombopenia. Penia means low, always after. When you see penia, is always low. Immune thrombocytopenia, That's the one that basically they were referring before. Immune thrombocytopenia is acquired immune-mediated disorder, newly diagnosis, persists in 3 to 12 months, chronic more than 12 months, and is diagnosis of exclusion. Okay. Thrombocytopenia, general mechanism, decreased platelet production, decreased platelet survival, splenic sequestration, those are when the patient has problem with the spleen, intravascular dilution or circulating platelet, that's maybe happen when you have a patient that you give too much fluid. Okay. Thrombocytopenia, common cause, bone marrow suppression from chemotherapy, recent immunization, alcohol ingestion. That's why alcohol is so bad because it produces a lot of problems. Low platelet, of course, and platelet is related to bleeding time. Okay, that's you see another relation right here. Low platelet, prolonged bleeding time. Okay, treatment based on identified causes. Okay, and in most of those diseases that you have platelet problem, basically you never give platelet to the patient. Okay, because uh, sometimes it's immune mediated. That means is the disease is immune mediated. That means that your immune system is attacking the platelet. You could give any uh, amount of platelet, doesn't matter because your body is gonna destroy all those platelets. That's why you have to treat the condition to improve the amount of platelet. Unless the platelet are extremely low, when I say extremely low, is less than 20,000, then you give the platelet transfusion. Okay. Platelet count, thrombocytosis. Again, that's right here. We have another terminology. Cytosis. Cytosis means too much. Okay, so thrombocytosis is too much platelet, over 400,000. Could be transitory because of stress or physical exercise. Could be primary. Polycythemia vera. Remember that when you have polycythemia vera, you increase not only the red blood cell, also white blood cell and platelet. Chronic granulocytic leukemia, secondary, respond to hemorrhage, disease process, or splenectomy. Splenectomy means that you remove the spleen from the patient. Thrombocytopenia, that's extremely important because the spleen is where you destroy the platelet. So if you don't have a spleen, you don't destroy the platelet. Thrombocytosis may lead to bleed or clot. Okay, treatment severe for primary reserved for primary etiology, cytotoxic agent, antiplatelet or interferon therapy. No treatment from transitory or secondary. And we have question number 2. A patient is found to have a tiny spot on the skin on his upper leg that are not raised and do not fail with pressure. Which term should the nurse use to document this finding? What is the answer right here? Yes, that's petechia, those little red dot that you have sometimes. But when you go to the gym, the people, when you go to the gym and you are doing exercise, you can see that sometimes you develop petechias. Now we have vascular and platelet disorder, quality, the platelet disorder, ability of the platelet to functions. Those are how the platelet function by adhesion, aggregations, and inhibit disorders. We have Bernard-Solier syndrome, von Willebrand disease, and thrombocythemia. We are going to see those diseases right now. Quality platelet disorder, acquired disorder is the more common one, and those are the signs and symptoms: petechia, purpura, skin, mucous membrane, epistaxis, gastrointestinal bleeding. Treatment is based in the underlying condition, sometimes require platelet transfusion. Coagulopathies are the effect of the normal clotting mechanism. Problem can include bleeding, from a problem with the formation, stabilization, or lysis of the fibrin clot, excessive clot formation. We are going to see consortium coagulopathies, DIC. We're going to see right later in this chapter. And right here we have hemophilia. Okay, hemophilia is a genetic disease and is X-linked. A and B is X-linked. Also remember that we have hemophilia C. It's not well described in all the books, but we have hemophilia C. Okay, hemophilia A. What you have to know is the hemophilia A, factor A. Hemophilia B, factor 9. Okay, and hemophilia C, factor 11. Hemophilia hemarthrosis, that's basically the harm. What is hemarthrosis? Somebody know what means hemarthrosis? No? Okay, it's easy. Hemarthrosis is bleeding in the articulation. Okay, how those patients are going to present? With inflammation, swelling of the articulation. Okay, they are going to have swelling of the articulation, and when you tap means that you put a needle, you're going to get blood. Treatment include patient, family education. Hemophilia A, you have to give factor A, and hemophilia B, you have to give factor 9. Okay. Now we have von Willebrand disease. Von Willebrand is an autosomal disorder of factor A. That's a mistake. That's complete error. Okay. Hemophilia, von Willebrand factor is an autosomal dominant disorder of factor von Willebrand factor. Okay, because von Willebrand is a factor. The only problem is that von Willebrand factor, they carry factor A, but the problem is von Willebrand factor. Okay. Causes is bleeding, prolonged bleeding time, and prolonged PTT. Okay, you can see right here, prolonged bleeding time, because von Willebrand factor is related with the platelet. Okay, in the activation of platelet, we need von Willebrand factor. Okay, because von Willebrand factor is released in the endothelium to activate the platelet. So von Willebrand factor is related with bleeding time and PTT. Why? Because it's a carrier of factor A, and factor A is an intrinsic factor PTT. Normal platelet counts and normal PT. Treatment, you have to give this desmopressin. Okay, that have another name, but I don't remember right now. Desmopressin, because desmopressin stimulate the release of von Willebrand factor in the endothelium. Okay, and also you have to give, you could give pure precipitate and avoid aspirin. Of course, if you have problem with bleeding, you never give aspirin to the patient. And now we have vitamin K. Vitamin K. Okay, I'm gonna explain vitamin K because you read the PowerPoint later. Okay, I don't like to. Most of the time, I don't like to go by the PowerPoint. But the PowerPoint is really important because it's where you get the information and you could read later. Okay. Okay, vitamin K is related with factor. You're gonna say how I remember is DISCO 1972. Okay, DISCO because it's protein C and S and factor 2, 7, 9, and 10. 1972. 10, 9, 7, and 2. Okay, that's how you remember. Vitamin K is extremely related with bleeding in neonates. Okay, you have to remember that because it's a question. Most probably it's a question in your test. Neonates. Neonate hemorrhage, vitamin K deficiency. Okay, why? Because vitamin K is produced in the normal flora of your gut. Okay, your gut means your intestine. In your intestine, we have flora. Flora is like bacteria under control. and those bacteria produce the vitamin K. When you are a newborn baby, you are basically sterile. You don't have any bacteria. New babies are sterile products that doesn't have any flora. So they can make the vitamin K. That's why newborn babies always you give a shot of vitamin K to avoid bleeding. Okay. Vitamin K deficiency, bleeding in infancy, that's the most common one. And I already explained this. Acquired vitamin K deficiency, remember the vitamin K is a fat-soluble vitamin, okay? Okay, fat-soluble vitamins, but that means that they need fat to dissolve that vitamin. And also, we need the biles, okay? That's why patient with pancreatic problem, patient with, there is a disease that is problem with the chloride channels. I don't remember right now, but it's a genetic disease, and those patients have problem with also vitamin K, okay, because they can absorb the fat soluble vitamin. The fat soluble vitamin is A, D, K, and E. Sorry, I have it right here. What is this? Okay, and E. Okay, those are the vitamin, the fat soluble vitamin. Okay. Acquired vitamin K deficiency increase PT, especially PT, due to the factors that are involved with vitamin K. They inhibit, they prolong, they increase PT and PTT. But normally we only measure PT. Why? Because out of all the chlorine factor that is produced by vitamin K, factor 7 is the one with the short lifespan. Okay, is the one that is gonna be inhibited first. That's why you only measure PT. Okay, treatment, parenteral administration of vitamin K, and treat the underlying conditions. Now we have DIC. You remember I talk about consumption coagulopathy. This is a consumption coagulopathy. Okay, DIC is an acquired hemorrhagic syndrome in which clotting and bleeding occur simultaneously. Okay, it's due to trauma, malignancy, burn, shock, abrupto placenta, or problems during delivery in pregnant women. Okay, and what happens due to those problems like trauma, shock, malignancy, you activate the coagulation process. Okay, when you activate the coagulation, you consume all the platelet or the clotting factor, and then you are at risk for bleeding. That's why those patients have bleeding, because they consume everything, because they activate the coagulation and they are at risk for bleeding. And because they activate the coagulation factor and they have a lot of producing a lot of coagulation, the D-dimers are extremely elevated in those patients. Okay. Fibrinogen levels of platelet count are decreased, PT and PTT are increased, and D-dimer and fibrin split products also are increased, because remember, they activate the coagulation. At the end of the coagulation, you have the dissolving of the clot, and the final product of dissolving of the clot are these. Disseminate intravascular treatment, removal, correction of underlying conditions, support major organ, fresh frozen plasma, and heparin is controversial. Okay. Hepatic disease, of course, coagulopathy result from impaired absorption of vitamin K, And also remember that if you have hepatic problem, you don't make the coagulation factor, okay? And then you are gonna be at risk for bleeding. The treatment, you have to give the vitamin K, and also you have to treat the underlying condition. That could be any condition that is affecting the liver. And we have question number 3. Question number 3, which disorder causes a patient body to clot and bleed at the same time? What is the answer? The answer is this, DIC, okay? Exactly, DIC. Any question from this chapter? No questions? Okay, then let's move to the next one. Listen, extremely important from this chapter, intrinsic pathway and extrinsic pathway, okay? Intrinsic pathway, factor A, 9, 11, 12, related with PTT, extrinsic pathway, factor 7, PT, okay? Problem with the platelet, increased bleeding time. So if you are taking aspirin or NSAID, you are going to increase platelet bleeding time. You are going to decrease platelet count, and you are going to increase bleeding time. Okay. Let's go to the next chapter. Let's see. Okay, now we have alteration in blood flow. Okay, we are gonna be talking about the flow in your circulatory system. Okay, now we have the circulatory circuit, absorption and delivery of nutrients. That's one of the functions of uptake and delivery. That means transport oxygen, removal of waste product. Lymphatic circulation, a specialized system and channel. Those lymphatic circulation also, they have vessels, okay? She absorbs fluid that leak from vascular network into the intestine and return to its general circulation. In the veins, we have the vessels, we have the arterioles, we have the venous, and we have capillaries, okay? Anatomy of artery and veins. 3 microscopically distinct layers, all of them are tunica. We have tunica intima, tunica media, and tunica adventitia. Tunica intima is the inner layer, and the main part of the tunica intima is the endothelial cells, okay? And endothelial cells have a lot of function, and also I'm going to ask a question to see some of you know the answer. What is the biggest organ in your body? Nobody knows you. Who say the skin?
Stephanie.
Megan.
Me, Stephanie.
Stephanie.
Yeah.
Okay, Mega also go with the skin. Nobody have another answer? Where you learn that the skin, the liver, no. Where you learn that the skin is the biggest organ in your body?
In anatomy.
In anatomy. Perfect. Okay, listen. The biggest organ in your body is right here. Vascular endothelium. That's the biggest organ in your body, okay? So remember from now on, unless, always remember that when you're taking a class, you have a book. That's why you have to always get a book, okay? Because the equations that you are gonna face in that class come from that book, okay? So if your book said that the skin is the biggest organ, in the test you have to answer the skin, but it's completely wrong, okay? That's used to be the biggest organ until we discover in medicine that the vascular endothelium is an organ that have 11 functions and is way bigger than the skin, okay? So you have a new information right now. Thanks that you are learning something at least from here. Okay, let's keep going. Also, we have the media. Most of the time, the media is muscle, and that muscle is a smooth muscle. And the adventitia is the outside layer, and is composed by connective tissue. Okay. Geriatric consideration, thickening of the basement membrane in microvascular. That's problem that happens when you are old. Geriatric means old people. Okay. Of course, when you are getting old, the blood vessels get like a stiffness. Okay, they don't move easily, and that's why in elderly population they are at risk to develop hypertension and problem with circulation. Okay. Also, another one is problem with collagen. That's why they develop disease. It's not a disease; it's a condition. Maybe you have a parent, a relative that is extremely old. You could see the skin that they bruise really easy, and it's because they have vascular, senile vascular, I don't remember right now, but it's capillary fragility. Okay, they have they are easy bruising. Anatomy of capillaries: single thickening of endothelial cell attached to the basement membrane. Spores: spore is extremely important in the capillaries because it's the one that allows the communication. Okay, especially right here in the kidney, in the glomerulus. Okay, in the glomerulus we have the filtration, the spores. I mean the space, the pores are the one that facilitate the communication. Okay, and also they form barrier. Okay, barrier. We have different type of barrier. We have blood-brain barrier, but also we have placenta barrier. Lymphatic structure is a thin wall of resembling veins, basically like veins, and they collect fluid that is outside of the blood vessels and put it back to the general circulation. That's basically the main function of the lymphatic system. Okay. Hemodynamic and circulatory system: principle of blood flow govern the quality of blood passage by a given point in a specific period, measured as a given number of liters, millimeters, or cubic centimeter per seconds, minute, or hours. And we have some principal flow. Right here we have blood flow, pressure, and resistance. Blood flow is the movement of the blood in the blood vessels, and we call laminar flow. Okay, that's the real name. That's the normal flow in the blood vessel. It's called laminar flow. Okay, because sometimes when you have alterations, that you have, for example, occlusion of one artery, then you have what is called turbulence. Okay, we have to be very careful with turbulence, because if you have turbulence, that means that the elements in the blood vessel, that the red blood cells start hitting the walls, and you could activate the endothelium. Pressure is the pressure that is inside of the artery of vein, and resistance is the opposite force, okay, in the blood flow. We have some law right here. You don't have to know this. That's like basically physics. Okay, you don't have to know this. And we have question number 1. And question number 1, which of the following is the major site of resistance in the vascular system and require a greater pressure to maintain blood flow? Okay, right here is the, no, is the arterioles. Okay, listen, I'm going to explain this, but I think for example, for your test, you don't need to know this, but in general, in medicine, you have to know this. The major resistance in our body is in the what is called the peripheral vascular resistance. Okay, peripheral vascular resistance is all the arterioles, okay, all the arterioles, the diameters of all the arterioles act together. Right there, you have the biggest resistance in your body. That's why when you treat a patient, one of the main factors for blood pressure is this one, the resistance in the arterioles. Okay, it's not the resistance, for example, in the aortic artery, that is the biggest artery in your body. No, it's not a resistance right there, because the aortic artery is just one, it's big, but you add all the arterioles, the diameter of all those arterioles together is going to be way bigger than the diameter of the uh, aortic artery. Okay, that's why peripheral resistance is the main component for blood pressure. Principle of flow, we have velocity, okay, velocity and laminar and turbulent flow. Okay, remember that laminar is the normal blood flow. Turbulence is when you have, for example, an obstruction. Okay, when you put the stethoscope, okay, that you inflate the stethoscope, you could see the artery right here. The artery is gonna be occluded. There is no blood running. Okay, right. When you release the pressure in the cuff, then the blood start running and produce the turbulence. Okay, parabolic profile of laminar flow, velocity of the layer of the blood flow within the vessels vary, with flow in the center moving faster than blood in the outer layer. Okay, we have turbulent flows is an interruption in the power currents of blood flow by crosswise flow. Okay, that's why I already explained and produce this. It's a bruit, it's a drill. Drill is, you hear the drills sometime when you have a murmur in your heart. Okay, and that's is we measure the degree of drills. Okay, because murmur have murmur 1, 2, 3, 4. Systolic murmur thing go from 1 to 6. Okay. Wall tension and compliance. Compliance means if the blood is reaching to that organ. Okay, that's compliance. Law of Laplace represent the relationship between distant pressure and wall tension, and increasing the radius or distending pressure result in increased wall tension. Okay, this part, and you have to check the review because there is not so much of this for your test. Okay, dynamic in the microcirculation, capillary and lymphatic exchange of gas and nutrients depend on pressure gradients between the capillary and the interstitium through balance of, and right here we have the pressure that facilitate the interchange of nutrients or gases. Okay, is the one that allow is the fluid, the content inside of the blood vessel go outside, or the one that is outside go inside. Okay, we have hydrostatic and we have colloid. Okay, hydrostatic is a pressure that is always pushing out. Okay, this is the blood vessel, is the lumen of the blood vessel, and hydrostatic pressure is a pressure that is pushing. Oh my god, it's like pushing out. Okay, like this, to leak out. And colloid oncotic is another name. Colloid oncotic osmotic pressure is the pressure right here, and it's driven by proteins that keep everything inside, okay? Right here. And inside the vessels, we have the capillary, hydrostatic, and capillary oncotic. But right here, we have also fluid, that is the interstitial fluid. It's the fluid between this lumen and another lumen, okay? For example, in cell is the pressure between one cell and to another cell, okay? So in right here also we have one pressure that is pushing in and one that is pushing out. And then you have to add and subtract all those pressure, and the final result is the net movement of the flow, okay? So is the final result is a number that is moving right here. That means that the volume from here is moving to this side. And if the number is bigger right here, that means that it's moving to this side, okay? That's a little bit complicated, but you have to know that hydrostatic pressure keep everything, push everything outside of the blood vessel, okay? Colloid pressure is driven by proteins and keep everything inside the blood vessel. That's why, for example, people with liver problems, remember that proteins in our body are made by the liver, okay, like albumin, okay? So if you don't produce albumin by the liver, you decrease the protein in your blood vessel and the liquid is gonna go out. And that's why patients with liver problem develop ascites. Ascites means fluid in the third compartment space, okay, especially in the belly. Let's keep going. We have another right here we have a Starling hypothesis is the net filtration is equal to the combined, is what I already explained. You have to add and subtract all those forces, and then the net result is the one that gives you in what direction the fluid is moving, okay? Capillary fluid pressure, hydrostatic pressure, this is the same. And you see you have problem, you could produce edema, okay? Plasma proteins are responsible for plasma colloid osmotic pressure, keep fluid in vessels, you see, change capillary permeability, and so is what I already explained. And we have question number 2. Question number 2 is, a patient has edema caused by heart failure and hypertension. In this situation, the edema has developed because of okay, listen. The answer is this one. Also, you have to know, listen, I already explained that colloid, okay, colloid pressure is related with liver problem, okay, because you don't produce protein. Also, that also is related with renal problem, okay, because sometimes when you have renal problem, you excrete, you eliminate a lot of protein, and then you decrease the amount of protein in your body. So renal problem and liver problem is related with colloid. Heart failure means that the heart is not pumping enough, okay? If the heart is not pumping, there is no hydrostatic pressure, because the heart is the one that produces hydrostatic pressure. Let's keep going. Control flow, blood flow controlled by central mechanism mediated by autonomic nervous system, venous system flow controlled by pressure gradient from vein and venous and thoracic pump. Intrinsic autoregulation mechanism, autonomic nervous system, that means the sympathetic and parasympathetic system, okay? If you activate the sympathetic, you have vasoconstrictions. If you activate the parasympathetic, you have dilation, okay? And venous is controlled by pressure, okay? And the muscular pump, okay? When you contract the muscles, you contract the veins, okay? Lymphatic flow controlled by increased interstitial fluid colloid of motor pressure and stimulation of contractile fibers. Control of blood flow, extrinsic mechanism, sympathetic nervous system, medulla vasomotor center responds to direct stimulation, and the excitatory inhibitor afferent stimuli. Major role in blood pressure. A smooth muscle in vessel is innervated by adrenergic fiber from the sympathetic nervous system. Okay, that's why the blood vessel, most of the time, body blood vessels are in a little bit vasoconstriction. Okay, and that's what keep maintain our blood pressure. Okay. Release of norepinephrine, of course, if you release norepinephrine, you are going to produce vasoconstriction. And release of epinephrine, you produce vasodilation via the beta-2 adrenergic receptor. Intrinsic mechanism, autoregulation, ability of the blood vessels, ability of blood vessels within organs to maintain and relative constant blood flow, regular change in arterial pressure. High blood pressure leads to a stretch that results in constriction of arterial and precapillary sphincter. Low blood pressure results in vasodilation, okay, to facilitate the blood to run. Okay? That's also our mechanism of defense in our body, okay? Hyperemia, local increase in blood flow, activate functional and reactive. Okay, let's keep going. Lymphatic flow, movement of lymph is enhanced by lymphatic pump, compression of lymphatic channels, intrathoracic pressure change, like when you breathe, you squeeze those blood vessels, lymphatic vessels, and you facilitate the flow, and lymphatic contraction, increase in BP, blood pressure. Reducing in flow impair ability to transport gas and nutrients to the body tissue, result in hypoxia, low oxygen, ischemia when you stop the oxygen delivery, venous engorgement, that sometimes because of ecstasy of the blood, and venous obstruction. Blood vessel obstructions may involve arterial or venous system. Okay, I'm going to explain that's clinically how you recognize that you have arterial deficits or venous deficits. Okay, clinically is really easy. Okay, you have venous obstructions, that means that you don't have return of the blood to the heart. The blood is gonna stay, it's gonna produce ecstasy in your body. So for example, in the lower limbs, if you have venous deficits, the blood is gonna stay in the lower limbs, and when you touch the patient in the leg, it's gonna be hot. Okay, the temperature increase. Okay, now you have problem in the artery, that means that you have obstruction of the artery, that means that you can deliver the blood to the tissue. If you can deliver the blood to the tissue, the extremity is gonna become pale and cold, okay? That's how you differentiate one to another one. Now we have thrombosis. Thrombus, a stationary blood clot formed within the vessels, causes blood flow slow dramatically, become more turbulence. That means that the the cells start hitting the endothelium and they can activate the endothelium and form the thrombus. Okay. Arterial thrombosis result in ischemia. Venous thrombosis result in edema. Okay? Ischemia means lack of oxygen. Edema means retention of fluid. Okay? Inflammation in the vein is called phlebitis. Inflammation with a clot in a vein, thrombophlebitis. Thrombosis clinical manifestation, arterial intermittent claudication. Those are the patients that have like arterial insufficiency. When they go out to walk, to do any activity, they have pain, okay? The description is basically when I walking, I have pain on my leg. That's claudication. When they start walking, the pain go away, okay? Venous is non or life-threatening pulmonary embolism, okay? Is producing the cough, groin, tenderness, swelling, and Hoffman signs. Okay, nobody know what is a Hoffman signs? You don't know what is a Hoffman signs? Okay, let me explain a little bit. Now you have an idea. That's the general idea. Actually, you don't have to know that. But Hoffman signs, you see right here. I'm gonna put my leg right here. You see? That's my leg. Hoffman signs mean that when you squeeze right here, the patient is gonna feel pain. That's the Hoffman signs. Okay. Basically, is nowadays no use. Is not in use. We don't use that sign, that test. Okay. But it's a test that used to be used to have an idea that the patient maybe have DVT. Okay. Deep venous thrombosis. Prophylactic intervention include oral parenteral anticoagulation therapy or drug that block platelet activation aggregation. Clopidogrel, Prasugrel, those are medication. Once a thrombus has formed, anticoagulant therapy is initiated to prevent clot enlargement. May need thrombolytic drugs, okay, TPAs. Additional medical prophylactic interventions, anti-embolic stocking or sequential compression device, ambulation as soon as possible. That's especially after surgery. After you have surgery, you have to put the patient to walk the next day. Don't wait like 3 or 4 days. No. You have the surgery today, tomorrow in the morning you have to start walking. The patient is gonna feel pain, but it's not gonna develop the pulmonary embolism. Embolus can be called thromboembolus, material that form and clot within the bloodstream, traveling clot. Okay, embolus leaving left ventricle, ischemic stroke. Okay, an embolus that is leaving the right ventricle, pulmonary embolism. You see right here, right ventricle, pulmonary embolism. Okay, embolectomy, that's the destruction of the embolus for thromboembolic, or a filter in the inferior vena cava. Okay, inferior vena cava filter. It's just a few indications for vena cava filter. Okay, emboli can be produced by other causes like fat embolism. Fat embolism is, for example, after trauma, when you have a broken bone, when you break big bones, the patient can develop fat embolism. Malignant is due to the malignancy from bacteria. Air embolism is for the scuba diving. People that do scuba diving can develop air embolism. Amniotic fluid, of course, You know what is amniotic fluid. You know what is amniotic fluid, yes? Pulmonary
Yes, the
emboli.
fluid that surrounds the baby when you're pregnant.
Exactly. Yes. Hold on, because I have a question right here. And you have a pulmonary embolus and only present with shortness of breath. Yes, you could have pulmonary embolus and it's only shortness of breath. Yes, it's like that. Not always you have you develop the sign and symptom of the DVT. Remember, actually those are two conditions. We have DVT, pulmonary embolism. Okay, in medicine we study both basically together because it's a continuation. Okay, but sometimes you have a DVT that you don't develop any sign and symptom in the lower extremity, and you develop the complication that is the pulmonary embolism. Okay, and right here also those produce pulmonary embolism. In fact, embolism produce pulmonary embolism. All these produce pulmonary embolism. Okay. Okay. Yes, yes. Can you hear me?
Yes.
It's perfect. No, I have some technical issue, but let's go. Okay. Now we have this that is vasospasm, sudden contraction of arterial smooth muscle result in obstruction of flow. Clinical manifestation of vasospasm, we have trigeminal angina. Angina is basically chest pain, okay? We have hemorrhagic stroke and migraine headache. All of them could be due to vasospasm, okay? And the medication that is used for vasospasm is calcium channel blocker, always nifedipine. Inflammation can be increased result of thrombotic process. Vasculitis is inflammation of the intima of the artery. Phlebitis is inflammation of the vein. Arteritis angiitis is inflammatory process of autoimmune origin in arteries. Mechanical compression, external force to the vascular systems that may result in complete or complete, in partial or complete obstruction, may be caused by trauma, tight cast, dressing, stocking, compartment syndrome. So trauma, all these, all the ones that are right here. So that means trauma, tight cast, dressing, and stocking lead to this. This is the condition. That's the actual condition. Compartment syndrome. Okay. That's what. And compartment syndrome, for example, right here. Okay. So when you put a cast right here, if the patient develop the P signs, okay, all the P. Oh my God, what is this? All the P's, okay, it's like 6P, like pallor, the extremity become like pale, pain, paresthesia, all sign with P is due to compartment syndrome. You have to remove the cast, and you have to do uh, fasciotomy. You have to cut the fascia because right here we have something that is called fascia that put everything together. You have to remove to cut the fascia. Let's keep going. We have blood vessels, type of structural alteration, valvular incompetence, superficial veins, that is varicose veins, deep veins, chronic venous insufficiency. Remember that in the lower extremity we have two vein circulation. One is superficial and one is deep, okay? Like for example, the femoral vein, that's deep vein, okay? Popliteal vein, those are deep vein. Then we have the superficial. Nobody know what are the name of the superficial veins? You don't remember from anatomy?
No, I don't remember.
No, okay, it's the saphenous. We have the greater saphenous, and I don't remember the other one, a smaller or lower saphenous, okay? Those are the superficial. When you have varicose vein, it's in the saphenous. That's why sometimes you have to do saphenectomy. You have to remove the complete saphenous vein. Okay, let's keep, oh, hold on. We were right here. Now we have arteriosclerosis and atherosclerosis. We are going to cover right those two, the difference between those two right now. Aneurysm is basically that you have the blood vessel and then you have like outpouching, one bubbles, okay? Arteriovenous fistula, that means communication. Fistula means communication between the arteries and vein, and sometimes it's due to arteriovenous malformation that is common in childhood, okay? Lymphatic vessels, change in capillary interstitial and cardiac pressure, increased filtration into the tissue result in edema. Lymphedema results from impair in the circulatory of the lymph, okay? And then that produces swelling. Alteration in arterial flow can result in obstruction that could be arteriosclerosis or atherosclerosis, inflammation, vasospasm, thromboemboli. Mechanical alteration, we have the fistula and the aneurysm. Atherosclerosis include three pathology process. In the artery, we have Mockenberg sclerosis, arterial sclerosis, and atherosclerosis is the most dominant. Mockenberg is a type of atherosclerosis, but is completely asymptomatic. Okay? Atherosclerosis develop in medium and large side artery. That's extremely important. Okay, right here. This Mockenberg is only in medium side. Process initiated by endothelial surface damage to the arteria intima, initiating an inflammatory response and increase in the vessel wall permeability. Now we have atherosclerosis. Is a low density serum lipoprotein beneath intimal layer. It's accumulation of that material and is the one that is going to produce the damage. Okay? Simultaneously, platelet aggregation at the site. So it's basically accumulation of a lot of material right there, and that form like atheroma plaque. Okay? And that atheroma plaque could be, you see, atherosclerotic plaque. They form the atheroma plaque. If that atheroma plaque is released, then produce obstruction later in the circulation. Okay. Let's keep going. Now we have identification and intervention directed toward modifiable risk factor. Modifiable risk factor is risk factor that we can work with those factors. Okay? We have the tobacco, injury endothelium, elevate LDL, decrease HDL. Remember, those are the cholesterol, okay? HDL is the good one, LDL is the bad one, okay? That's why LDL has to be high and LDL has to be low. This vasospasm, ladies, you don't have to worry so much about that because thanks to the estrogens, your HDL is always high, okay? That's why the risk for coronary artery disease in female start at 55 years old. In male, start at 45. You have 10 years advantage. Let's keep going. Increase BP and heart rate, increased risk of coronary artery disease, cessation of smoking, 50% risk reduction in coronary artery heart disease in 1 year, and risk for coronary heart disease is the same after 10 years with the normal population. Atherosclerosis, that's when you stop smoking, and that's related with coronary artery disease. But if you are smoking for 10-15 years and you stop, the lung damage is completely irreversible. Okay, so you could be like the rest of your life without smoking. This previous smoking that produced damage in the lungs, that's not gonna go back. Okay? Because it's completely reversible. Identification. We have other risk factors. We have hypertension, increase the risk. Hyperlipidemia, that is cholesterol, lipoprotein, and triglyceride, also increase the risk. Glucose intolerance, metabolic syndrome, all that increase the risk. Obesity increase the risk for atherosclerosis and coronary artery disease. How we manage those those factors? One of the measurement is physical activity, because physical activity increase HDL. Basically, it's the only way that you increase HDL, physical activity. Okay, because basically there is just one medication that increases HDL, that is vitamin. I don't know. I don't remember right. It's one vitamin. I think vitamin B3. Stress and mental health. Stress and depression increase the risk for atherosclerosis, of course. And those risk factors are the ones that we can modify, okay? Like the age, gender, family. Diagnosis, Doppler flow. Doppler flow is to see if there is any obstruction in the veins, especially. This plethysmography is another test. Angiobrachial index is to see you have problem in the arteries. Okay. Exercise stress test is to see you have obstruction in the arteries also. Angiography is basically to see all the veins. Okay, you basically paint all the veins with one substance and you see all circulation. First line treatment is non-pharmacological interventions such as weight loss, smoking cessation, exercise. And if not successful, then you have to give medication. Okay, and surgery, you could do the stents, angioplasty, or CABG. That's the CABG. And we have question number 3. Which statement is true regarding atherosclerosis? Okay. And remember, exactly, remember that atherosclerotic is in the medium, in the large and medium size, okay, right there. That's extremely important. Okay, now we have some problem in the arteries, okay? We have thromboangiopathy obliterans, that's the Berger disease. It's a rare inflammatory condition affecting the small and medium-sized arteries and veins, okay? And the treatment, the main treatment is a smoking cessation, okay? Raynaud syndrome or Raynaud phenomenon is when a patient is exposed to a cold weather, they have like cyanosis of the digit right here. You have cyanosis right here, and it's due to vasospasm, okay? And that condition could be sometimes present in another diseases, okay? You could read right here, and the treatment always for vasospasm, calcium channel blocker, okay? Aneurysm is localized anterior dilation bulging upward of the one part of the artery, classically classified as true or false aneurysm. True aneurysm include saccular, fusiform, and berry. Berry aneurysm is especially in the brain, okay, in the circuit of Willy. You remember the circuit of Willy in the anatomy? Right there in the circuit of Willy. Remember what is the most common artery of the circuit of Willis that is at risk for berry aneurysm? Yes? How? It's the anterior communicating. That's the most common for berry aneurysm, okay? Frequently found in the cerebral circulation and thoracic and abdominal aorta. In abdominal aorta is called the triple A. Triple A in medicine doesn't mean American Airlines Arena, means abdominal aortic aneurysm. Now we have aneurysm, clinical manifestation, cerebellar, increase intracranial pressure, hemorrhagic stroke. The most common sign and symptom of berry aneurysm is the worst headache of my life. The patient is gonna complain, the worst headache of my life. Have to do a CT scan without contrast to see the bleeding, to identify the bleeding. Dissecting aortic aneurysm, medical emergency, and most of the time is due to trauma, okay, trauma. Triple A abdominal aortic aneurysm is extremely related to smoking, okay? That's when there is a prophylactic. Every patient over 65 years old that have smoked at any time in their life, you have to do abdominal sonogram to look for triple A, okay? And you remember that I tell you the compartment syndrome, those are the sign and symptom of compartment syndrome, you see? All the P, all the P's.
Professor, sorry to interrupt. What does AAA stand for again?
American Airlines Arena. No, that one is closed. Okay, it's abdominal aortic aneurysm.
Okay,
I
thank
think it's
you.
open again. I don't know. But, you know, when I say something stupid like that, sometimes that gets stick in your mind and
Oh, it
it's
does work.
better to
That's how I learned everything in anatomy.
yeah,
Relating it to something else.
to the normal life. Listen, one important aspect in the learning, first you have to do repetition, and the other one is that you have to relate all those material, all those concepts that are extremely hard with your normal living life, okay, with your daily life, okay, and that's how you remember. You see right here the 6 P's, all the P: pallor, paresthesia, paralysis, pain, color, pulseless, okay, and those are the same sign and symptom for compartment syndrome, because compartment syndrome is a artery obstruction, okay? The treatment is loose tight dressing, okay, called the gas, anticoagulation therapy, thrombolytic, bypass, embolectomy, amputation. Amputation is the last one. First you have to recover the limbs, and then you do the amputation. The limbs, listen, upper limbs and lower limbs, they are extremely resistant to lack of blood supply, okay? So if the blood supply to the brain If you stop the blood supply to the brain after 5 minutes, you have irreversible damage, okay? In the limbs, in the upper limbs, you could stop the blood supply for 1 hour, you are normal. In the lower, I think it's 2 hours, okay? You could maybe later when you become like nurse, if you work in the orthopedic surgeon, you work with one orthopedic surgeon, you are gonna see that sometimes when you are gonna do a surgery, you do something called that is desanguination. So you have to put like something really tight right here, and you do a tourniquet right here to remove all the blood. Because when you are doing surgery, blood is just to bother. Alteration in blood and venous flow, incompetent valve, of course, due to obesity, pregnancy, right heart failure, prolonged standing, producing varicose vein, chronic venous insufficiency, obstructed by deep vein thrombosis, okay, accompanied by edema, venous ecstasy, ulcer, and pain. So first, that's the sequence, okay? Right there you have the sequence, basically. You first develop edema. Edema is due to ecstasis, and this leads to ulcer. Deep venous thrombosis can be life-threatening. Why? Because produce P, 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 okay? Pulmonary embolism. Valvular incompetence, overstretching of the valve owing to excessive venous pressure results in backflow of blood, result in venous insufficiency, venous varicose vein, treatments, smoking cessation, regular walking exercise, and drug, okay? Varicose veins, impaired venous return, resulting in superficial darkening, raised and tortuous vein, greater saphenous vein, most commonly affected. The treatment is increased venous flow and reduced venous pressure. Sclerotherapy, that's basically that you put electricity and you burn the vein. Chronic venous insufficiency result in when valvular incompetence. Remember that the veins have like valves, okay? Is the vein in the middle, they have like a valve, okay? Those valves are the ones that facilitate the venous return to the heart, okay? Now we have the ultrasound. Of course, you have to do the ultrasound, and then when you do the ultrasound, you put the Doppler. Doppler, when you see the blue and red, to see the circulation. And right here we have deep vein thrombosis, most frequent because of thrombus in a deep vein of the lower extremity. One of the main signs and symptoms of deep vein thrombosis is, of course, swelling, okay? Don't say inflammation, it's swelling of the lower limbs, okay? And one of the main difference with other diseases is that deep vein thrombosis is always, basically always unilateral, okay? So if you have swelling of the both lower extremity, most probably is due to congestive heart failure, liver problem, other diseases. But when you have just one sign with predisposing factor, what are the predisposing factors? Is the patient that doesn't move for a lot of time, other predisposing factor for deep venous thrombosis, then you start thinking in deep venous thrombosis. Treatment aggressively with anticoagulation therapy. Previous DVT is a risk factor for further hypercoagulation. Lymphedema is obstruction of the lymphatic system. Okay, primary lymphedema results from congenital abnormality and destruction of the lymphatic system. Secondary lymphedema associated with a disease process or iatrogeny. Iatrogeny means that is produced by the by doctor. For example, when you do radical mastectomy in ladies that you have breast cancer, that you remove the breast, most of the time, basically always you remove the lymph node. If you remove the lymph node, then you produce iatrogenic lymphedema. And then we have filariasis is by Washeria bancrofti, that's worms, a parasite that produce filariasis, and also the people call as elephantiasis. Okay, those people that have one leg that is extremely big is due to that parasite right here. Okay, this parasite. Most common in the United States, lymph node removal or radiation therapy. Okay, when you do. Also, we have lymphedema, typically affect extremity, is not treated, brown edema and large deformed limb, primary diagnosis tech, injection of radioisotope. Okay, treatment medical, external compression, therapy, exercise. And we finish right here with this chapter. Any question?